In this video, we are going to cover flowcharts and tables from the topic of STEMI, that is ST elevation myocardial infarction. So starting with table 1, definitions of myocardial injury and infarction. So what is myocardial injury? In a cardiac cell, the contractile apparatus is present inside the cell, which contains actin, myosin, and troponin. So whenever there is any cardiac injury, the troponin from inside the cell leaks outside, and that is why troponin values inside the blood increases. And if one of the value is above the 99th percentile of the upper reference limit, then this is known as myocardial injury. Then what is myocardial infarction? If along with this myocardial injury there is any one of the following, like symptoms of myocardial ischemia or new ischemic ECG changes or development of pathological Q waves, or any imaging evidence of new loss of viable myocardium or new regional wall motion abnormality in the echo, which is consistent with an ischemic etiology, or identification of a coronary thrombus by angiography or autopsy, then that is known as myocardial infarction. And based upon the etiology, the myocardial infarction has been divided into 5 types, and this is important for the examination. Type 1 MI is our classical myocardial infarction. In this, inside the blood vessel, there is plaque, and if this plaque gets ruptured, a thrombus is formed. And because of this thrombus, the blood supply to the myocardium is cut off, and hence this part undergoes ischemia. This is our classical type 1 myocardial infarction, and you can identify this MI in angiography or during the autopsy. Now coming to type 2 myocardial infarction. In type 2 MI, there is demand or supply mismatch. Suppose there is hypotension or shock. In that case, the blood flow is decreased because the blood pressure is low, and that is why the supply of blood to this particular myocardium is low, and hence there is myocardial infarction. And the other way around is whether the patient is having tachycardia or the patient is in arrhythmia. In that case, the demand of this particular myocardium is high, and this blood supply is limited, and hence there is supply and demand mismatch, and this is known as type 2 myocardial infarction. Third is type 3 myocardial infarction. Suppose a patient comes to our emergency with the classical symptoms of myocardial infarction, but in that patient, before even you can take the blood, the patient collapses. Then that is known as sudden cardiac death, and this is type 3 myocardial infarction. Type 4 MI is PCI related, and for this particular MI, the troponin value should be more than 5 times of upper reference limit, and this is further divided into 3 types. First one is type 4A. This is related to the procedure. Like when you are putting the stent, if there is any artery dissection, this is known as type 4A. In 4B, you have already inserted the stent, but there is thrombosis of that particular stent, and that is type 4B. And in type 4C, there is restenosis of the particular stent. This is type 4C. Now talking about type 5 myocardial infarction. This is CABG related, and in this the cutoff of troponin value is more than 10 times of upper reference limit. So for type 4 and type 5 particularly, along with this troponin limit that I have told you, this one of the following criteria should also be fulfilled, and this include new onset ischemic changes or development of new pathological Q waves or any imaging evidence which shows loss of viable myocardium that is presumed to be new, any ischemic changes, and this pattern should be consistent with the ischemic etiology, or any angiographic findings which is consistent with the procedural flow limiting complication such as coronary dissection or occlusion of major epicardial artery or a graft, side branch occlusion, thrombus, disruption of collateral blood flow, or distal embolization. Apart from that, no other thing you should remember from this chart. Then, one particular type of myocardial infarction is silent myocardial infarction. Sometimes in the diabetic patient, they develop MI and they do not present with any of the symptoms. That is known as silent MI. So, how do we know that patient had MI in the past? So, these are the following criteria. In the ECG, we can see abnormal Q waves with or without symptoms in the absence of non ischemic causes, or there could be any imaging evidence of loss of viable myocardium in a pattern which is consistent with ischemic etiology. Or during autopsy, there could be pathoanatomical findings of prior myocardial infarction. Now coming to the ECG findings of ST elevation MI. In STEMI, there should be new onset ST elevation of the J point from the baseline in at least two contiguous leads, and the cutoff for this increase in the baseline is 0.1 millivolt, more than equal to 0.1 millivolt in all the leads except V2 and V3. For V2 and V3, the cutoff are different, and these cutoffs are different in male as well as female and based upon age as well. Like in female, the cutoff is 0.15 millivolt, and in male there are two cutoff. If the age is less than 40 years in male, then the cutoff is 0.25 millivolt, and if the age is more than 40 years in male, then the cutoff is more than 0.2 millivolt. Now coming to the mechanical complication of ST elevation myocardial infarction. So there are three mechanical complication and only the highlighted points you have to remember. So what are these three mechanical complication? So this is our heart and this is the pericardium. So because of ischemia, there could be a rupture of the ventricular septum, and this will act as ventricular septal defect. The other thing which is possible is the rupture of the free wall. If this free wall gets ruptured, then the blood will come from the ventricle in the pericardium, and this will act as tamponade. And the third thing which is possible is rupture of the papillary muscle. So this is the valve, this is chorda tendineae, and suppose this is our papillary muscle. If the papillary muscle gets ruptured, then the valve will be left free, and this can also act like mitral regurgitation, and this will lead to increase in the pulmonary capillary wedge pressure and pulmonary edema. So these are the three type of mechanical complication. So in this you should only remember that in ventricular free wall rupture, fibrinolytic therapy does not reduce the risk, and only PCI can reduce the risk of this complication. Apart from that, the time course is same for all the three complication. They have bimodal peak, which means that the first 24 hours the risk is highest, followed by in the next 3 to 5 days. Then the clinical manifestation that you can read, like chest pain, breathlessness, and the other findings. Then physical findings are important because this ventricular septal rupture, it act as the ventricular septal defect, and that is why while auscultation you will hear hollow systolic murmur. In rupture of the ventricular free wall, there is cardiac tamponade features like jugular venous distension, or there could be pulsus paradoxicus or electromechanical dissociation, and patient could also present with cardiogenic shock. And in papillary muscle rupture, there will be severe pulmonary edema. Then the echo findings, this will be the same only based upon the findings of the mechanical complication. And then right heart catheterization, this could be asked in the examination. And because there is ventricular septal defect in the ventricular septal rupture, there is increase in the oxygenation, that is oxygen saturation from Ra to Rv, whereas there is no increase in the oxygen saturation from Ra to Rv in papillary muscle rupture, and in both of them V waves are very large. And for ventricular free wall rupture, the ventriculography is very insensitive. Now coming to the management of ST elevation MI. So this is a practical point that whenever a patient comes with chest pain, within first 10 minutes, a first medical contact should assess the patient, and this first medical contact should be able to take an ECG and all, and as well as interpret the ECG. And if this ECG shows ST elevation MI, then this algorithm is followed. So this algorithm is further followed based upon the hospital where the patient is taken first. Suppose in the nearby hospital PCI is available, so you can directly take the patient to the cath lab, and there within 90 minutes you should get the angiography done, And in this angiography, based upon the result, you can further go for PCI, that is percutaneous intervention, or CABG, based upon how many vessels are involved. And if not a PCI or CABG, the patient might only require medical therapy. Then, suppose you have taken the patient to a non PCI capable hospital, then there are two possibilities. First, that the nearby hospital, the patient could be shifted to the nearby hospital within 30 minutes, and there within and after entering the hospital within 90 minutes, patient could be shifted to cath lab, and door to balloon time in that hospital is 90 minutes. Okay, so if this is the case, then directly shift the patient to the nearby PCI hospital. And if this is not possible, and if there is delay of more than equal to 120 minutes, then it is better to give the fibrinolytic therapy to that patient in that hospital only, because in STEMI the time is muscle. So each and every second that you lose, the patient is continuously losing the myocytes. So the patient will develop ejection fraction, the less loss of ejection fraction with time. So that is why you just give the medication in that hospital. And after giving the fibrinolytic therapy, there are two possibilities. First, after giving the medication, do an ECG. And in the ECG, first thing is that the ST elevations have resolved and the patient is having decrease in the symptoms. In that case, you have to monitor the patient for 1 to 3 hours. And after 1 to 3 hours, shift the patient to the nearby PCI capable center. And in that center, we will get the angiogram done, and we will do either PCI, CABG, or only give the medical therapy. Other thing is that the ST elevation has not resolved and the symptoms are persistent. In that case, it means that our fibrinolysis has failed. In this, you have to urgently shift the patient to the nearby PCI hospital for rescue PCI. There also, after doing the angiogram, we will decide whether the patient needs PCI, CABG, or only the medical therapy. And you should remember that if the patient is having cardiogenic shock or severe heart failure initially at the non-PCI capable hospital, then he should be transferred for cardiac catheterization and revascularization as soon as possible. And this is irrespective of the time delay from myocardial infarction onset. And angiography and revascularization should not be performed within the first 2 to 3 hours after administration of fibrinolytic therapy. Now coming to the last flowchart, which is primary prevention of sudden cardiac death with ischemic heart disease. So once a patient develops myocardial infarction and while doing the echo, you notice that the ejection fraction is less, which is less than equal to 40 percentage, then the patient has a risk of developing sudden cardiac death at any point in his or her life. So here you should first see when was the last MI. If the MI was within 40 days or the revascularization was done within 90 days, then you should do electrophysiological study. And during the EP study, if you see that the patient has inducible sustained ventricular tachycardia, then this become class 1 recommendation for inserting an ICT. And if there is no sustained ventricular tachycardia, then you can just continue the directed medical therapy for this patient. The other thing that you can do is to give a trial of WCD, that is variable cardioverter defibrillator. So this will sense the rhythm of the heart and it will revert back to the original rhythm. And after 40 days or after 90 days of revascularization, you will again look for the ejection fraction. And if the ejection fraction is still less than 40 percentage, then you will look at the functional status of the patient. Suppose if the patient is having NYHA class 1 functional status and the ejection fraction is less than 30 percentage, or the patient is having NYHA class 2 or 3 symptoms with ejection fraction of less than equal to 35 percentage, then both of these become class 1 indication for ICT insertion. Other thing is, suppose if the patient is having less than or equal to 40 percentage of ejection fraction, but the patient is also having non-sustained ventricular tachycardia or inducible sustained ventricular tachycardia on the electrophysiological study, then in this scenario also you will insert an ICT. If not, then you can only continue with GDMT, that is goal directed medical therapy. Then in functional status 4, this is the tricky one to remember as well. So if the patient is symptomatic even at rest. And if the patient is participating for any advanced heart failure therapy, then whether this advanced heart failure therapy like heart transplant or LVAD, that is the left ventricular assisted device, whether this can be given to this patient or not. If this is possible, then only insert the ICD. And if advanced heart failure therapy is not possible, then there is no role of ICD insertion, because if the further therapy is not possible, in that cases arrhythmia is most commonly not the cause of the sudden cardiac death, and hence you should not put the ICD, and this will help us to prevent the sudden cardiac death.